be introducing our distinguished speaker properly in due course. My name is Bola Owolabi, MBBS class of 1997, and I'm currently the president of ICOMAA UK and Ireland. We have a program of events to guide us sequentially through the webinar, and we will try and keep to time. Ladies and gentlemen, permit me to observe some due and important protocol in acknowledging important dignitaries and personalities amongst us today. Not because it is a tradition, but because we cherish the presence of these people amongst us today and always, and more so for the record. Now, I'd like to acknowledge our mother of the day, Professor Mrs. Aderunke Manuel Olumide, a retired professor of public health, community medicine, health systems, administration, and management. You're welcome. I think I'm going to have to go over that again for the records. Good afternoon, good morning, good evening, everyone. Welcome to the second ICOMAA Worldwide Quarterly webinar hosted by our chapter ICOMAA UK and Ireland. Thank you all for joining us today. This webinar is going to be an exciting one, educative one, and interesting session. The title of today's webinar is Progress in Partnership. We will be introducing our distinguished speaker properly in due course. My name is Bola Owolabi, MBBS class of 1997. I'm currently the president of ICOMAA UK and Ireland. We have a program of events to guide us sequentially through the webinar this afternoon and also to time us. Ladies and gentlemen, permit me to observe some due and important protocol in acknowledging important dignitaries and personalities amongst us today, not because it is a tradition, but because we cherish the presence of these people amongst us today and always, and more so for the records. Firstly, I would like to acknowledge our mother of the day, Professor Mrs. Aderunke Manuel Olumide, a retired professor of public health, community medicine, health systems management, and administration. You're welcome, ma'am. Also, I'd like to acknowledge our distinguished chairman of this webinar and the person of Professor Rotimi Jayesimi, consultant obstetrician and gynecologist, associate medical director, Mid and South Essex NHS Foundation Trust. You're welcome, sir. Also, our esteemed speaker, Professor Bola Owolabi, Commander of the British Empire, who we will duly introduce later on with a citation. I want to acknowledge the presence of the President of ICOMAA Worldwide, our dear Emeritus Professor Sam Omokodun. You're welcome, sir. I also want to welcome the chapter presidents of ICOMAA and the person of Dr. Modupe Shokumbi, ICOMAA North America, Dr. Yomi Shubowale, ICOMAA Canada, Professor Akishola Akimbi, ICOMAA Australia and New Zealand, and all members of the chapter executives present here today. Distinguished past presidents of ICOMAA Worldwide, in particular, our own Professor Oladipo Otolorin. I'm not sure if Professor Otolorin is here, but I'm sure he will join us in due course. Also, other past presidents of ICOMAA joining us. I'm trying to look at a list so that I can duly recognize them, but if they're here, I want to mention Professor Mrs. Wura Olashokunbi, Dr. Habib Olamitoye, Dr. Ade Fatai Adeniyi, our immediate past Deputy Provost of the College of Medicine. Also, I'd like to acknowledge our past Vice Chancellors who may be present with us today, in particular, Professor Isaac Folorunsho Adewale, current Ambassador of Nigeria to Canada. Our Deputy Vice Chancellor, Academic Professor Juwon Arotiba, is present today. Our past Deputy Vice Chancellors who may have graciously joined us as well. I'm trying to catch the list. Our chief host, the Provost of the College of Medicine, Professor Temidayo Ogundiran, or the representative of the provost. Our past provosts here present, Professor Olayinka Omigbodun, Professor Temitayo Shokunbi, Professor Akinyinka Omigbodun, Professor Bumi Olaopa. If they're present, we acknowledge you. We also would like to acknowledge our distinguished Chief Medical Director of the University College Hospital in the person of Professor Jesse Abiodun Otegbayo, or the representative, if they're present here. We also acknowledge our past CMDs who may be present in this webinar. Thank you. Now, with great joy and honor, I also acknowledge in our midst our living legends, Emeritus Professor Oluwole Akonde, OON, who is always present in every program organized by ICOMAA anytime, any day, and is one of the greatest supporters of ICOMAA UK and Ireland. We welcome you, sir. We will acknowledge dear Professor Mrs. Onodeko, Professor Fola Esson, who is present here. I can see dear Professor Esson's name. Dr. Adekola Ashaye, I'm not sure if he's here. I think I saw Dr. Ashaye's name earlier on. We acknowledge you, sir. You're welcome to this webinar. Now, I'd like to acknowledge the Deputy Provost, Professor S.B. Olaleye, and all past Deputy Provosts here present, our present deans and past deans of our faculties, distinguished members of the college and usage management teams, if they're present here, Professor Kola Adeshina, Chairman, Medical Advisory Committee, and Professor Olushola Ibiebi, Deputy Chairman, Medical Advisory Committee, who is my friend and classmate. You're welcome, sir, Mama. Distinguished members of the ICOMAA Worldwide Webinar Committee, led by Professor Adanze Asinobi, who has worked tirelessly to make sure that this program holds today. I want to acknowledge you, ma'am. Also, our hardworking and dependable ICOMAA UK and Ireland Webinar Committee member representing us, Dr. Eno Usoro. Other members of the ICOMAA Webinar Committee, in particular, Associate Professor Olubukola Olaleye, you're welcome. I want to acknowledge the presence of President of Ibadan Medical Specialist Group, UK, Dr. Bode Williams, and members of the executive. You're welcome, sir. The co-chair of the global sponsor, a students program in the person of Dr. Bisi Oshinkolu, you're welcome, ma. Thank you for joining us. The co-chair of the ICOMAA New Hostel Building Committee, Professor Gbemisola Oke, and Professor Major General Retired Shino Ogunbi, you're welcome, sir and ma'am. Members of the building committee present here, Dr. Banji Adeyoju in particular, Dr. Yemi Adedeji, and other members of the hostel committee, you're welcome. Our distinguished alumni worldwide, with whom we're all extremely proud, thank you for joining us this evening. Friends of our College of Medicine, University of Ibadan, all over the world, you're welcome to this webinar. Distinguished ladies and gentlemen, friends of the alumni and college, ladies and gentlemen, welcome to our program today once again. And I want us to know about some housekeeping rules so that we can seamlessly enjoy this evening. Ensure that you mute yourself all the times and only unmute yourself if you want to speak. And if you have any question or comments, please use the chat box and we will pick it up from there and address that during the question and answer session. Now, this webinar is recorded and you can all have access to it at some time. If you are on the group or forum, you'll be able to directly access them once it's finished. Thank you all for joining us this evening for this important webinar. Now, I'd like to invite our chairman of today, Professor Rotimi Jaisimi, for his remark. Thank you, sir. The floor is yours, sir.
Lovely. Good evening, Dr. Ajulaya. Thank you for the kind introduction. The first and the best. That is who we are as the University of Ibadan. I will stand on existing protocol, and first and foremost is to say a big thank you for the honor accorded me to chair this afternoon's webinar. I must pay special honor and greetings to Emeritus Professor Wole Akonde, as you rightly said, ever present at every event organized by the College of Medicine. Also to Emeritus Professor Samuel Omokodian, pediatrician of great repute, Professor Olumide, public health, who was also my tutor. And I say a warm good afternoon to you. Distinguished guests, eminent alumni, dear colleagues, ladies and gentlemen, good evening. And a warm welcome to this special ICOMAA Worldwide webinar. It is my great honor to serve as chairman of today's occasion. And it's also a pleasure that we will be hearing from an eminent speaker in the person of Professor Owolabi. I'm sure we cannot wait but to hear from her. We expect Professor Owolabi to challenge us, to inspire us, and most importantly, to show us practical pathways through which alumni, institutions, governments, and international partners can work together to produce measurable progress. To all our alumni joining from Nigeria, the United Kingdom, the United States of America, Canada, Europe, other parts of Africa, and beyond, whether you are a fresh graduate or a distinguished emeritus professor, your presence here today affirms that the spirit of Ibadan remains strong and united. Let us listen and open minds, engage with sincerity, and leave this webinar with renewed commitment to our partnership with the University and College of Medicine. With these words, it is now my pleasure to hand over to Dr. Ajilaye, who will introduce Emeritus Professor Omokodian, the ICOMAA Worldwide President, to give his remarks. Once again, I'm looking forward with excitement to this webinar. Thank you, Professor Owolabi, for accepting to come and share your knowledge with us. So over to you. Thank you.
Thank you, Professor Rotimi Jaisimi, for such a wonderful remark. And it's my great pleasure, without wasting time, to bring forward our own dear President, ICOMAA Worldwide, Emeritus Professor Samuel Omokodian, to give us a grounding remark for this webinar this evening. Thank you, sir. You're welcome to the stage.
Good evening, everyone. It is my great pleasure to make this brief remark at the onset of this particular edition of the ICOMAA webinar series. And I want to similarly observe the protocol already established, except to add that I saw, while many were coming in through the waiting room, Emeritus Professor Babatunde Onadeko, as well as Professor Mrs. Modupe Onadeko. These were great teachers, and I acknowledge you're taking time out to be part of this event. Now, also so delighted as chairman, and I identify with you, that we have this webinar holding as the second edition. As far as I am concerned, it has come to stay. There are so many alumni of Ibadan College of Medicine worldwide who are excelling in their chosen areas of endeavor. And I think many, if not all, deserve to be showcased on a global platform of this nature. Not just because we wish to showcase the first and the best, Ibadan College of Medicine, University of Ibadan, but also because it is necessary to inspire those who are coming on and to show that if you are diligent in your ways, in whatever you do, as the scriptures say, you will stand before kings. And our speaker today, who will be introduced specifically for the day, is one such example who has excelled and has gained recognition beyond what many of us would know. Again, I would not like to preempt the appropriate introduction, but I want to congratulate her for excelling and doing us all proud on the global platform. And we are proud not just to showcase you, but we know that you will be an inspiration to many of our younger colleagues who are coming, even contemporary colleagues. And like the chairman has mentioned, we can't wait to hear the lecture you have so kindly accepted to deliver today. And I am sure, like I have pledged, this will be recorded not just on the platform for today. This will be recorded in print as well as electronically, so that it can be accessed on our website. It can be noted and become a reference material for those who would like to take a similar path. And without further delay, I want to congratulate also the webinar organizing committee and the hosting chapter, the UK and Ireland, who have worked so hard to ensure that we have this event today. Well done, and we owe you a debt of gratitude for all the efforts you have put in to bring this to reality. We will be looking forward to subsequent chapters, also similarly hosting the next webinar. Well done, and we look forward to this quarterly series. And these will be made available, as I have said, not only on the website, but electronically, so that everybody can have access to this material. Thank you, Mr. Chairman. Thank you, Dr. Ajileye. Thank you, Mother of the Day, for accepting this role to honor us with your presence. And thank you, all senior fellows. This is the only opportunity I may have to all, because I have got to save time, past provost, host provost, past vice chancellor, chief medical director, everyone that has taken time out to be with us this evening. We honor you. We are grateful for identifying with this move, and may the God continue to bless and promote you. Thank you very much.
Thank you, sir. Dear President Emeritus Professor Samuel Omokodion, for such a wonderful remark and the promise to ensure that ICOMAA always lead the way. You know, your examples of leadership has been quite inspiring for us in a chapter, and the effect is felt globally as well across other chapters. Thank you so much, sir, for always being there to pick our call and to give us guidance anytime we need. Thank you. Now I'm going to invite the chair of the webinar committee, Professor Adanze Asinobi, to speak to us about this webinar and why the webinar, and then we'll proceed with the rest of the program. Thank you. Professor Asinobi, kindly take the stage. Thank you.
Thank you very much. It is with great pleasure that I, on behalf of the webinar committee of ICOMAA Worldwide, welcome you, revered, very distinguished teachers and leaders and mentors in the field of medicine and health administration, to this second webinar organized by the ICOMAA Worldwide. With me in this webinar committee are very distinguished, dedicated, and indefatigable alumni of the College of Medicine, Ibadan, namely the overseer, I will call him, Emeritus Professor Samuel Omokodion, the president of ICOMAA Worldwide, whose brainchild the quarterly webinars is. Amongst us is Dr. Modupe Shokumbi, the president, ICOMAA North America. Professor Rufus Owolabi, the financial secretary of ICOMAA Worldwide and our rep for the representative for the home front, is amongst us. Associate Professor Obioma Uchendo, the ICOMAA Worldwide PRO, is with us. Amongst us also are Dr. Eno Usoro, the rep for the UK and Ireland, Dr. Moses Ademola for Canada, Dr. Oluwole Oyeniyi, the rep for Australia and New Zealand, and Dr. Lola Akinitire, the ICOMAA Worldwide Administrator and Secretary. I want to welcome everyone, distinguished friends of the College of Medicine, friends of ICOMAA, friends of UCH, who have joined us today, and our family members who have honored our invitation. The inaugural webinar was hosted by the ICOMAA North America under the leadership of Dr. Modupe Shokumbi, who is an excellent physician, excellent administrator, our own wife and mom, and everything went well to the glory of God. The father of the day, on that 31st of January 2026, when the inaugural webinar took place, was our highly revered Foundation Provost, who needs no further introduction. I must say, as others had echoed, that he's always with us, with the provost, the administrators, the staff and students of the College of Medicine, providing guidance and counseling. Emeritus Professor Oluwole Akonde, thank you very much for being here today. We appreciate you, sir. The inaugural webinar was chaired by Professor Solomon Kadiri, the wise Solo, as our late revered Professor O.O. Akinkugbe used to call him. Thank you, sir. The first lecture, titled From Guidelines to Practice, Key Updates and Insights from the 2025 American Heart Association and Hypertension Guidelines, was excellently delivered by Professor Modele Oguniyi. That was an outstanding performance. We say thank you and that we are proud of you. Today, we are privileged to be hosted by the UK and Ireland region of ICOMAA. They have worked very hard to make this possible. And we are grateful to the mother of the day, Professor Mrs. Aderonke Manoa Olumide, for accepting to be with us today. We are grateful to our chairman, Professor Rotimi Jaisimi, who didn't hesitate to accept this responsibility. We are grateful to the president of ICOMAA, United Kingdom and Ireland, Dr. Ajileye. We are grateful to our eminent lecturer that we caught amongst her very complicated and programs, but she obliged us by creating time to talk to us today. Professor Bola Owolabi, we appreciate you and we are proud of you. The representative of the president of ICOMAA, UK and Ireland, Dr. Nosoro, a very dedicated alumna, very hardworking, did everything to ensure that this held smoothly. I want to thank ICOMAA members, both young and old, for being here today to listen to our guest lecturer. Our College of Medicine is the first and the best. We are leading in Nigeria. And this opportunity for us all to come together, have this connection with the advantage of further collaborations in future, showcasing who we are for the good of mankind and for the good of Nigerians, cannot be overemphasized. So I encourage us to please make it a priority to attend these meetings. The next meeting will be hosted by the Home Front, and will hold in the next 3 months. And please ensure that you make room, create time to attend the next meeting whenever we call upon you. I must use this opportunity to also thank the ITU team of the College of Medicine, led by Mr. Sunday Oyetunde, who ensures that the webinars go smoothly. I want to thank everyone who has honored our invitation and ask you to listen attentively, and I'm sure you will be satisfied. Thank you, and God bless you all. Thank you.
Thank you very much, Professor Adanze Azinobi, webinar chairman, webinar committee chairman. Thank you so much for such a wonderful speech. I think we're going to proceed now, but we need the blessing of our mother, the mother of the day, Professor Mrs. Aderonke Manuel Olumide, retired professor of public health, community medicine, health system management and administration. If Professor Olumide, please speak to us, and then we'll continue with the rest of the program. Thank you, ma'am. Hello, ma'am. Okay. We'll get our mother of the day to speak to us later on as we progress in the webinar. Now, may I invite Dr. Eno Usoro to give the citation and introduce our distinguished speaker for today to the audience. Dr. Usoro, over to you. Thank you. You are muted, Dr. Usoro. Okay.
Thank you.
Now we can hear you now.
Okay. Good evening, everyone. I will stand on existing protocols. It is my absolute pleasure to introduce Professor Bola Owolabi, CBE. Professor Owolabi has just taken on the role of Chief Inspector of Primary and Community Services at the Care Quality Commission, CQC. She joins the CQC after serving as NHS England's National Director for the Healthcare Inequalities Improvement Programme, where she led the groundbreaking Core 20+5 approach to tackling health inequalities across the country. She also serves on the board of the CQC as an executive director and also as a non-executive director on the boards of NHS and national housing organizations. In addition, she is the chief executive of Wordsmiths Global, where she advises boards, community groups, and senior leaders on health equity and leading complex change. Alongside her national leadership, she continues to practice as a general practitioner, something that keeps her grounded in the realities of frontline care. Her work has brought together integrated care models, service transformation, and data-driven improvements to drive real, measurable change. And her influence extends far beyond the UK. She has collaborated internationally with the Yale School of Public Health in the US, the Commonwealth Fund, and the World Economic Forum's Health for All network. Professor Owolabi was appointed by the United Kingdom's Secretary of State for Health and Social Care as co-chair of the government's 10-year health plan workstream, helping to shape a future-focused model of care that sits at the heart of the government's health mission. Earlier in her career, she was a National Specialty Advisor for Older People and Integrated Person-Centered Care at NHS England, leading the anticipatory care workstream of the National Aging Well program. She also contributed to the COVID-19 Ministerial Task Force during the pandemic. Professor Owolabi holds a master's degree with distinction in leadership for quality improvement, is an alumna of Ashbridge Executive Education at Holt International Business School, and is a recipient of the NHS Leadership Academy Award in Executive Healthcare Leadership. She's an honorary professor at the University of Birmingham's Institute of Applied Health Research and serves as Vice President of the Royal Society for Public Health. And in 2025, she was awarded a Commander of the Order of the British Empire, CBE, in the King's Birthday Honours for her outstanding contribution to reducing health inequalities. And may I add that I'm very proud today to be the one reading her citation because I remember Professor Owolabi as a very pleasant senior in school. She was actually a year my senior in medical school. So it does me great honor to be the one to read her citation today. Please join me in welcoming Professor Bola Owolabi. Thank you.
Thank you so much, Dr. Osuro, for your very kind introduction. I similarly stand on all observed protocols, and thank you most sincerely for the invitation to address this esteemed group this evening. My distinguished lecturers, eminent teachers, honored peers, it does me great honor to be here this evening, and I'm incredibly grateful for the opportunity to be here. Before I say any more, I also would like to acknowledge, honor, and thank my late father, Engineer Yekini Ajani Akinyemi, my wonderful late mother, Mrs. Hannah Adebola Akinyemi, without whom this day wouldn't exist. All that has been read out today is because of their working their fingers to the bone. They were not people of great resource, but they were people of great determination. They were people of incredible grit who saw to it that their kids had the best education that they both could afford. I honor them today. Today is because of them. I'll do my best to share my slides. Do bear with me and wish me luck, because sometimes the best laid plans don't always go the way you intended, but I hope you can see my slide. I can no longer see you all, and so if my attention is required, I would be incredibly grateful for a verbal cue, as I now can't see you. So these are my affiliations as very kindly introduced. And the speech today is going to focus particularly on my role at NHS England as National Director for Health Inequalities. And it's the work that was done in that role that led to His Majesty King Charles III very kindly honoring me with the Commander of the Most Excellent Order of the British Empire in his July 2025 birthday honors. And so I want to talk through the progress that we made, and that was indeed through partnership. My personal vision is exceptional quality healthcare for all. I underscore for all because I include in that people who find themselves at the peripheries of society, those who are marginalized, those whose voices are seldom heard, those who don't necessarily have resources or agency to argue and advocate for themselves. When I talk about exceptional quality healthcare for all, I include them. And that we pay attention to three dimensions: that people have equitable access. It's not about the equality of access, it's about the equity of access, because equality makes a fundamentally flawed assumption that we all have the same starting point. And no, we don't. Some have extra ladders, some have extra boxes to stand on. And so it's about equity of access. And that when people do gain access, that they have an excellent experience of their care. And it's the combination of those two things that ultimately lead to the optimal outcomes, which I believe is the reason why we're all here gathered and why we do the work that we do. When I joined NHS England at the height of the COVID-19 pandemic in January of 2021 and was appointed as National Director for Health Inequalities, that happened in the context of a pandemic that cast a very harsh light on pre-existing health inequalities. There was a fallacy at the beginning of the pandemic that the COVID-19 pandemic was the ultimate leveler. Of course it wasn't, because we soon realized that whilst we all weathered the same storm, we did not weather that storm the same. People who were at the front line, people who had no choice but to show up at work each day, were a million miles separated from those who lived in 5-bedroom houses, with dedicated studies, with gardens who had the benefit of being able to avoid the virus completely. What the COVID pandemic did, however, was it exacerbated pre-existing inequalities, and it forced them into our consciousness in a way that probably only a pandemic could have done. And so when I arrived in my role, I noticed that there were a number of paradigm shifts we needed in order to be able to make progress. The first was because of decades of publishing about health inequalities. The first organized body of work that was published in the UK on health inequalities was the Aitchison report in 1979. And subsequently, we've had several reports published. And that's led to a sense of paralysis by analysis, whereby health inequalities were too difficult because they'd been around for all of these decades. At best, when people tried to tackle them, it became a tick box exercise, or it became an exercise in pontification rather than actually doing anything about the problem. Or we made general sweeping statements of ambition that really didn't make a difference in anyone's life. And so my job was to support and enable a number of paradigm shifts. And the first was to move health inequalities from that too difficult pile and to force the system, the NHS, to focus on those things that were and are within our spheres of influence, and to identify those tangible next steps we could do something about and make a difference in people's lives. The second was to move that tick box exercise into a more considered approach that led us to specific programs of work and make decisions that could enact real change. And from eternal pontification of the problem to creating innovative solutions that could drive quality improvement. And my biggest bugbear of all, to move from making sweeping statements of ambition to actually action plans, deliverables, explicit strategies that would lead to demonstrable impact. These were the shifts that we needed to achieve together. And so my team and I, we set about understanding clearly what that sphere of influence was. And the first was around the fact that at the time, the government had published its health mission, which was about reducing the gap in healthy life expectancy and improving overall healthy life expectancy. That was a powerful policy lever that we anchored ourselves to as the basis for the work that we needed to do. Secondly, at the time, the government had also been talking about the 10-year health plan and what it intended to do as a result of the plan. Unfortunately, a focus on health inequalities was a centerpiece of that 10-year health plan. And again, it became a powerful lever for us. Also, the government on an annual basis mandates NHS England, the organization that I worked in, with a set of deliverables. And we worked really hard to ensure that the stark inequalities experienced by so many people remained part of that annual government mandate to the NHS. I had the opportunity of working with government lawyers as the Health and Care Act of 2022 was making its way through the Houses of Commons and the House of Lords to ensure that actually the health inequalities provision in that piece of legislation were the strongest they'd ever been. Also, at the time, the NHS was developing its oversight framework, and this is the framework by which all NHS organizations are held to account. And so my team and I worked incredibly hard to make sure that the NHS oversight and assessment framework centered health inequalities. Also, the NHS was being organized around the integrated care systems, and we lobbied hard to make sure that one of the 4 priorities for the integrated care systems was to tackle inequalities in access, experience, and outcomes. I'm taking time to set this out because one of the reasons why we stall sometimes, even when our ambitions are laudable, is we don't always identify the axis of influence that we have and legislation and policy are underused, and yet they can be some of the most powerful levers for influence that we do have. The other thing we needed to do was to set out some very clear priorities, because up until that time, there was a sense that health inequalities were complex, ambiguous, amorphous, even nebulous. And people wondered, where exactly do we start? And one of the jobs of leadership is to clarify for people what are the priorities in addition to the vision, because we do need to give people a clear, positive, powerful picture of the future. That's what a vision is. But visions only stay on a dashboard until people know the practical next step to take. And so one of our responsibilities was to set out those priorities. And the first was, as we emerged from the COVID-19 pandemic, to restore our NHS inclusively and make sure nobody was left behind. The other is that we had pivoted, understandably, onto a digital footprint for delivering healthcare. But I was mindful that there is such a thing as digital exclusion. Not everybody can afford the smartphones. Not everybody has access to the data to be able to connect with us. And so mitigating against digital exclusion became another strategic priority for us. We also realized that a lot of people are often missing from the data sets, particularly people from ethnic minority communities. And so ensuring that data sets were complete and timely, particularly as it pertains to people from an ethnic minority background, became another one of my priorities. Also to pivot into that preventative space so that we're not only picking people up when they've already experienced the worst outcomes as a result of inequitable access or suboptimal experience. And finally, to strengthen leadership and accountability, because we recognized that these other priorities may as well not exist, because without leadership, without accountability, these are simply talking points. And so those were the things that we set about doing. We then needed to give the system a clear framework for action, because up until that time, there was a sense that there wasn't a lot the NHS could do, on the basis that health inequalities are driven for the most part by the social determinants of health: housing, education, household income, all of the societal drivers that were deemed to be beyond the purview of the NHS. But my argument was the National Health Service is the recipient of the largest proportion of the GDP in the United Kingdom. And for such an institution to abdicate its responsibility in tackling health inequalities was untenable. And so what we did was to create a framework for action called Core 20 plus 5. To arrive at this framework, we combined 3 data sets: the Commonwealth Global Burden of Disease Survey, Public Health England segment tool, and the Slope Index of Inequality. And once those 3 data warehouses were triangulated, they showed us that the 20% most socioeconomically deprived communities, the core 20, plus other population groups like ethnic minority groups, people who live in coastal areas, traveler communities, the plus, they are the ones who experience the worst of health inequalities. And so Core 20 plus 5 has 2 broad dimensions. One, a focus target population, that's the Core 20 plus. And the 5 are the clinical areas that are the biggest drivers of premature mortality, or the biggest disparities in premature mortality. And so you end up with maternity, severe mental illness, chronic respiratory disease, cancer, and cardiovascular disease. And across all of those, smoking as a common denominator of health inequalities. This is the Core 20 plus 5 for adults. We also set about developing Core 20 plus 5 for children and young people. And in this case, the Core 20 plus population are essentially the same, but the clinical areas are different because it's not on the basis of premature mortality, but it's more relating to access to care. And so we have asthma, diabetes, epilepsy, oral health, and mental health. But having defined all of those strategic frameworks for action. We needed an ecosystem for delivery, because the reality is, without a delivery ecosystem, Core 20 plus 5 will simply be a pretty infographic, a footnote in history, without ever being able to articulate the precise difference that it made. And so we built an ecosystem for delivery that included our connectors, trusted voices, trusted faces in communities, the accelerator sites, our ambassadors, and leveraging the innovation ecosystem of the UK. And we partnered as well with the Institute for Health Improvement from the United States. So I just wanted to give you a sense of the backbone of the work that we did. And so in terms of making progress through partnership, it wasn't up to NHS England as a lone entity. We worked with organizations like the Academic Health Science Networks. We partnered with the Accelerated Access Collaborative in developing a program of delivery called Innovation for Healthcare Inequalities, INHIP. I commend it to you. It was actually evaluated and the impact report was published a couple of years ago. And through INHIP, we were able to reach those Core 20 plus populations who would not normally come forward to have their hypertension diagnosed or optimally managed, those who lived with chronic respiratory disease from those communities that were described as hard to reach. I argue that they're not hard to reach, they're seldom heard, they're easy to ignore, but most certainly not hard to reach. And what INHIP was about was to leverage the innovation ecosystem to reach them, also in terms of early cancer diagnosis, so that we stopped the travesty whereby the poorest people tended to be diagnosed with late-stage cancer in accident and emergency at stages 3 and 4, and that was happening in 24% of circumstances. And so this is one of the collaborations and partnerships that we drove forward. We worked with the Caribbean and African Health Network, a grassroots organization present within the community, trusted by Black Caribbean and Black African communities. This was vitally important because in January of 2021, the UK quite rightly said that we were world leading in terms of the COVID-19 vaccine, because at that point we were at 82% penetration of the vaccine for over 80-year-old people. But that only told you a part of the story. When that data was disaggregated, in Black African people, it was actually more like 38%. In Pakistanis, 44%. In the poorest people, 45%. A distant cry from the 82% headline figure. And so I was on the phone to the pastors of some of the largest churches in the UK, the imams of some of the biggest mosques, the leaders of the Gurdwaras, asking for their help to help us reach the communities, amongst whom the vaccine uptake was the lowest and mortality was highest. And one of the organizations that supported us was CAN. They went around knocking doors, addressing people's legitimate concerns. I know we talked a lot about vaccine hesitancy. People weren't simply hesitant for no reason. They were hesitant because, as they said to me and the Minister for Vaccines at the time, these vaccines were not tested in people like us. The research was not necessarily done by people like us. People had legitimate concerns. However, what we couldn't afford was for those legitimate concerns to continue to lead to suboptimal uptake of the vaccine, because the mortality rate became unacceptable, particularly in our communities. And so we partnered with CAN. And by July of 2021, we had gone from 38% uptake in Black African people to 70%. This is the power of partnership. Furthermore, the NHS Race and Health Observatory, an organization that I had the distinct privilege of being their senior responsible officer and their budget holder, and had the privilege also of establishing this organization during my tenure at NHS England. I commend the RHO to you. One of the latest things they've done, and I really want to bring this to our attention, is to ensure that the NHS performs extended gene typing, because we realized that many of our people had adverse outcomes from chemotherapy because of the different bioavailability that we're all familiar with, but we simply were not actually testing enough in terms of the range of gene variants. And I'm delighted to say that only last week, the NHS has ruled that out. But actually, during the pandemic, what the NHS Race and Health Observatory was able to demonstrate was the fact that pulse oximeters that were being used to determine whether people were escalated to ICU or indeed HDU, their readings were inaccurate in people with darker skin tones because they hadn't been calibrated for us. And that gave me leverage to speak with the Secretary of State at the time. And he commissioned Equity in Medical Devices Review, led by Professor Dame Margaret Whitehead, and that report was published. And now the Medicines and Healthcare Regulatory Authority, the MHRA, is launching its equity in regulation to make sure that going forward, all devices are adequately tested across different skin tones so that we don't end up with the scandal that happened in the pandemic where people with darker skin tones, African people, Asian people, did not have their care escalated in the way that they should have been. This was another incredibly impactful partnership. And also they helped us in terms of this NHS Innovator Accelerator, which was a specific program that we stood up, again, to drive forward Core 20+5. I now want to talk about the partnership with the National Institute for Health and Care Research, NIHR. I am grateful to Professor Lucy Chappell, their chief executive, who partnered with me and actually launched a series of calls, funding calls, £50 million for each section of Core 20+5. And that started with a call, a maternity inequalities calling, really in this area, that was launched about 18 months ago. And the latest was launched at the beginning of this year on the cardiovascular diseases element of Core 20+5. And this challenge call will continue under the auspices of the NIHR. Progress is made through partnership. Additionally, the NIHR now has inclusion as a condition for research funding. This is a landmark. It means that every researcher, every research organization that now applies to the NIHR, you need to demonstrate how traditionally excluded communities will be included as part of that research effort as a condition of funding. This is going to make a material difference for generations to come, well beyond my time and the time of many of us on the call. In terms of sickle cell, we've made some significant advances, and I really do want to acknowledge Amanda Pritchard, Dame Amanda Pritchard, who was at the time NHS England's chief executive, who supported me by investing in a multi-year, multi-million pound project to improve sickle cell. I lost 5 cousins to sickle cell, and for me, this was a personal vendetta. And I am absolutely thrilled to say that we got to a position where the United Kingdom became the first country in the world to make the gene editing therapy, Casgevy, available on the NHS for those who suffer the most debilitating forms of sickle cell disease. Casgevy offers functional cure. For the first time, there is hope for those people whose lives were riddled with sickle cell crisis after sickle cell crisis and could not fulfill their potential. I am grateful to the NIHR, to the MHRA, to the National Institute for Health and Care Excellence, NICE. All of those organizations had to agree. All of those institutions had to be convinced for us to get to a point where this gene editing therapy that cost £1.6 million per person for it to be available for those people who had little or no voice. This is the difference that partnership makes. As the South African proverb says, if you want to travel fast, go alone. But if you want to go far, you have to travel in company. We got to a position where we were able to establish sickle cell bypass units in large NHS organizations so that people who appear and turn up in crisis aren't waiting in a queue. There is a dedicated bypass pilot area for them. We launched the blood group genotyping in partnership with Genomics England. We were able to advance prescription savings. It becomes really expensive when you live with a long-term condition like sickle cell. And I'm grateful to the Department of Health and Social Care for this savings campaign on people's prescription. Progress is made through partnership. This is what was done in London, where similar to stroke, because we had the Act Fast acronym, and it got to a position where people around the country understood stroke without having to be a medic. We wanted that to also be the case for sickle cell crisis, for members of the public to be able to notice, recognize, and seek help for people in a timely manner. And this is how Act Now became a thing. And this was in partnership with the Sickle Cell Society. In partnership with my current organization, the Care Quality Commission, we were able to develop this framework to ensure that when we develop solutions and interventions, we do so in partnership with the communities who are experiencing the greatest inequalities. Because oftentimes we develop these solutions and interventions in our ivory towers, and it's no longer they do not work. Because of course, the best laid plans only survive contact with the fog of war if you have bothered to co-produce and co-design with those who are most affected by the issue at hand. And so in partnership with the Care Quality Commission, and for those who may not be familiar with the CQC, this is the independent regulator of all healthcare and adult social care in England. And I'm privileged to be with the CQC now as the Chief Inspector of Primary Care and Community Services. As I mentioned before, through the partnership that we had with the NHS Race and Health Observatory, we were able to convince the then Secretary of State for Health and Social Care to commission this independent review on equity in medical devices with all of the recommendations that it published, and these are now being taken forward. In collaboration with the World Economic Forum, I have the privilege of being a member of the Global Health Equity Network. Again, we looked at what is it that places can do to advance health equity even on a global stage. And we published this white paper in September of 2024, how we close the health gap through collaborative action to make sure that we do have place-based change that is not divorced from the cultural nuances and implications of the place where the inequality is occurring. And only in the last month or so, again in partnership with the World Economic Forum, we were able to publish this Making Rare Diseases Count. And I'm delighted that when you read the report, you will see that sickle cell has a significant mention, because that is my personal interest. This is one of the rare diseases, individually rare, but collectively common, and only rare when you're talking about the United Kingdom context. It is not rare when you're in Nigeria or in Africa. And so I'm absolutely delighted that the World Economic Forum has published this seminal paper, which I'm hoping is going to drive action on a global stage around rare diseases in general, but sickle cell in particular. The World Health Organization talked about the need for us to look at digital health. And I'm pleased that I happened to be in Copenhagen a couple of years ago, and I was approached about the work that we had done in NHS England. We published the NHS Digital Inclusion Framework. And on the basis of that, I was asked for my opinion about what regulation needs to look like as we regulate and evaluate digital health. And this paper was published only last week. Again, progress is made through partnership. We then worked with the Race Equality Foundation because we noticed that actually when it comes to things like cardiovascular disease, we have a higher incidence and higher prevalence, and unfortunately, higher mortality and morbidity in Black African and Black Caribbean communities. But the uptake of blood pressure checks and other interventions is dismally low. And so we worked with the Race Equality Foundation to develop culturally appropriate communication to explain precisely to people in a culturally meaningful way why this matters in terms of their annual physical health checks, which, by the way, is free on the NHS, and therefore heartbreaking to see that people with severe mental ill health, for whom the cause of death is not usually as a result of their mental ill health, but as a result of cardiometabolic complications of that condition, the annual physical health check uptake was desperately low in Black Africans. And so we worked with the Race Equality Foundation, who helped us to get this culturally competent communications available. I then worked with an organization called HQIP. They receive funding to deliver all of the audits that are done by the National Health Service across the United Kingdom. And we noticed that many of the audits were not disaggregated. The data emerging were not disaggregated either by socioeconomic deprivation or by ethnicity or other dimensions of inequality. And I'm pleased to say that in working in collaboration with them, this report was published in 2022, and subsequently all HQIP audits are now intentionally designed with a view to the data being publishable by disaggregated analysis of ethnicity, socioeconomic deprivation, and other inclusion health dimensions. We've mobilized a huge amount of resources, and I only put this here because I hope the slides will be shared so that those who want to have a look and see what other assets are available, particularly around tackling digital exclusion, which for us in the UK is quite a significant issue. These resources are there to support you. And finally, I just want to end here. I was honored to be asked by the current Secretary of State for Health and Social Care, the Right Honorable Wes Streeting, to chair one of the work streams of the 10-year health plan. The 10-year health plan has been published, and this is the document that is guiding the work that the NHS is going to do over the next 10 years, all the way through to 2035. And in collaboration with my colleague Jacob Lant, we were asked to chair the work stream titled I'm Treated in a Fair and Inclusive Way, Irrespective of Who I Am, essentially the health inequalities work stream of the 10-year health plan. It is the honor of my life to have been asked to do this, and that document stands as a legacy of the contribution of a Nigerian, of a University of Ibadan alumna, of the College of Medicine alumna to UK health policy over the next decade. All of this was recognized by His Majesty. I'm very grateful to my parents. I'm very grateful to my distinguished teachers. I'm very grateful to friends and colleagues along the way who have supported me, encouraged me, spurred me on, even to greater heights. I will end there and just say, we only make progress, we only advance by focusing on our spheres of influence, embracing our agency to act, refusing to be paralyzed by analysis, making the pivot from analysis to action, from the eternal rhetoric into the reality of people's lives, and translating policy into practice. But all of that gains greater traction when we work in partnership with others. Thank you.
Right. Thank you, Professor Bola Owolabi. That was quite inspirational, thought-provoking, and a call for action. I'm sure the attendees, we can see so many emojis going on, applause going on, and that's to show that what you have given us today has been very, very useful. Thank you for acknowledging your parents because not all of us remember to do that, even when they've gone. So kudos to you, Professor Owolabi. One of the things you said was that we should focus on things that are within our own sphere. And I think one of the things we all think is we have to be in this big space, in this big position to be able to influence change. But that's not the message. The message is brighten the light in wherever you are. And I think, secondly, before we go into the question and answer session, is that we have to be at the table to be able to make a difference, to be able to influence policy. And I believe you're speaking mainly to a Black audience today in the webinar, mainly Nigerians. And you spoke about inequalities, equity, access. All of these, again, apply to our continent. It applies to Nigeria as a country. And so the key message is the partnership, progress through partnership. And you've mentioned a lot of institutions that you had to work with to get to where you are. And I'm also delighted about the achievement with sickle cell, because sickle cell disease in Nigeria, I think we have the largest number of people living with sickle cell disease. So before I call on to people to use their electronic hands, it's just once again to say a big thank you for the work you do and for the recognition that you have given to us as a race and as a people and as an alumni of the University of Ibadan. So over to questions. I wonder if you do raise your hands, I think you will be unmuted, allowed to speak and ask your questions. Please, let's make it as brief as possible so that we can take as many questions as possible. So over to you, Professor Fola Esson. Professor, can she or he be unmuted if she's not? Professor Esson.
Yes. Good evening, everybody. Thank you, Professor Owolabi, for that very excellent lecture. I wonder what is happening. This may not be your direct area, as much as you have outlined all the changes that you are making, all the assignments that you have helped. There seems a situation in which the staff of NHS is constantly now unsatisfied. There is hardly any quarter of the year when there is no strike. Why, with all this work that you are doing and all the accolade that you are getting, the junior doctors especially and the nurses appear to be going on strike? Almost at least once a year, there will be some form of strike at the NHS, which is worrying to those of us who, in the older days, used to quote for the benefit of the NMA that they should look at the BMA that almost never went on strike. That's my question. Thank you once again.
Thank you so much, sir. It's a really important question, and you're right. Talking about spheres of influence, that is beyond my sphere of influence. However, I acknowledge the point that you're making, that the level of dissatisfaction is quite considerable. And it's multifactorial. As we all know, it's not just about remuneration, it's about working conditions, and various things, and changing expectations. I do remember when I was a junior house officer here in the UK, 84-hour week was a given. I'm not saying that it was right, but that was the reality at the time. Whereas quite rightly, the expectation of the current generation is very different. And I think there's something about the system catching up with those different expectations. My son is now in his final year in medical school here in Newcastle. And I'm encouraging him to understand what a privilege it is to serve patients. And that, you know, if what we were trying to achieve is to be wealthy, there are other professions where we can achieve a lot of that. Medicine really is a vocation, and it's about service. And I'm trying to get him to understand that, because I think that that's probably been lost somewhere in translation. That's not to say that there aren't things that can be done to improve people's working conditions, and I would strongly advocate for that. But I also think that there does need to be a reconnection with medicine as a vocation.
Lovely, thank you. I've got co-facilitators who would look into the chat in case we do have any questions written in the chat for you. That will be Associate Professor Olaleye and Dr. Usoro, if there are any, but there are hands raised at the moment. So there's somebody called Ade's iPhone. Ade's iPhone. Please, your question, please make it brief.
Can you hear me?
Yes, we can hear you.
Well, my dear brother, I'm sure you will recognize my voice as being Adewale Adebajo. Good afternoon, everyone. Based on Professor Esfon's excellent question, I just want to make a quick point. I didn't know Professor Owolabi, but a mutual friend introduced us very briefly. And I gave her a little bit of advice, and I completely forgot I'd even ever met her. And then out of the blue, she emerged, and she was telling me that the advice I gave her was so amazing. Already, Professor Jayasimi, you have referred to the presence of Emeritus Professor Onodeko. And I just want to say that in the same way, Professor Onodeko has helped me to get to the little that I've been able to achieve. So the small point I just want to make is that, particularly in the presence of our teachers, is not only to thank you for your investment, but that even as a teacher now myself and as a professor, my desire is that those who come behind me should do even better than me. Unfortunately, there's the Nigerian concept of removing the ladder. But I see in Professor Owolabi and many other people like Professor Nadeko, the desire that those who they mentor, they teach, they help, should even overtake them. And Professor, I only have MBE. Professor Owolabi now has CBE, and it gives me joy that she has overtaken me. And I just say, the little that you invest in people, by God's grace, will yield dividends in the future. And our desire should be to help people, no matter where they come from, who they are, not expecting anything, but knowing that we are investing in people. And Professor Owolabi is an amazing testimony to that. Professor Owolabi, as you know, I'm so, so proud of you. I was there at your birthday party and was dancing with my wife. You are an amazing lady. Thank you so much.
Lovely. Thank you, Wale, for that. Well, thank you so much, and greetings to Nike.
May I respond? May I respond, sir?
All right, please do.
Thank you so much, Professor Jaisimi. Professor Adebajo, can I thank you? I hadn't realized you were on the call. Can I thank you in the presence of all gathered? And I would like to share a very short anecdote, if I may. I arrived in the UK in 2001, straight after my medical school exams, because my husband already lived here. And I remember approaching so many professors from Ibadan, from around the country, for help. And almost without exception, and it breaks my heart to share this story, but it's important. My husband and I were made to feel really small. We were made to feel irresponsible until I had the good fortune of being introduced to Professor Wale Adebajo. And from the first conversation that we had, he was realistic, he was pragmatic, he stated the facts, but he did so with humanity and not cruelty. He didn't promise me heaven and earth. He was clear about the mountain that I had to climb, but he was also clear that that mountain could be overcome. He made that transformation in my journey in the United Kingdom. I was surprised he didn't remember me when I rang him years later to thank him. And I just want to echo what he has just said. We just never know. You know, that very thin 23-year-old, 24-year-old has a destiny that God knows. And sometimes all we need to do is to just be the one who puts up that ladder to just help them get on the first rung. I'm grateful to you for doing that for me, sir.
Yeah, thank you, Professor Owolabi. I think participants might wonder, what's the relevance of all of this? That we're here to talk academia, progress through partnership. But what we have just heard from yourself and Professor Adebajo, again, is showing through partnership, individual networking, the progress we can make as a people. And it's a message I would like to leave with each and every one of us. Let us pull the younger ones up that ladder. Let us not be the sole shining star in the sky. Let us build a community through partnership. So thank you, Wale, for the help you rendered. Over to you, Dr. Ajile. You've got your hands up for a while. Thank you.
Thank you so much, Professor Jayasimi. Thank you, Professor Bola Owolabi, for such a very illuminating lecture. And thank you for accepting to represent us. And we're so proud of you delivering this lecture today. My question is that listening to you, I could say that you work in several spheres with bilateral, multilateral agencies, with governments and all that. I'm just wondering, what impact does government change, regime change, for example, in England? We know it's a very, very dynamic system. What impact does that have on the work that you do going forward?
Dr. Ajile, thank you again for inviting me to be here. As you've rightly said, the political environment is so dynamic, and I'll share what helps me. It's the power of the pivot, and recognizing that regime change in itself or administration change doesn't necessarily mean the end of our ability to be impactful, but we do have to pivot. So a lot of the things I shared with you happened under a conservative government. And historically and traditionally, people may say that that is perhaps the more challenging environment within which to address matters of health inequalities. But nevertheless, we were able to. As a matter of fact, a Labour government is more naturally attuned to tackling health inequalities than a conservative government is. The job of leadership is to pivot. It's really important that we craft a narrative that is fit for its time. And so a lot of the narrative that we talked about under the conservative government was about the economic case for tackling health inequalities. I spoke to colleagues at Deloitte, and they published a paper titled "The US Cannot Afford Health Disparities." And from the point when that paper was published, the level of attention that health inequality started to gain in the UK and beyond was phenomenal, because we pivoted the narrative from a moral and ethical imperative to a business case. And so, how does the change of administration impact the work that I do? I would suggest the work that we all do. I think what it should do is to prompt us to pivot, craft a new narrative, hold the core the same, but core a new narrative that is fit for the particular prevailing dominant discourse that we find ourselves in, and align with the current discourse. And then what we find is that rather than people wanting to push back, they are recruited to the cause. The job of leadership is pivots and narrative crafting.
Lovely, thank you. I'm sure that answers the question. Olufunso Adedeji, Mr. Adedeji, over to you.
Okay, can you hear me?
Yes, we can.
Professor Owolabi, thank you very much for that wonderful and erudite talk. Two or three questions. One is about how much, obviously, got a lot of things I'm learning today. And as a colorectal surgeon, I wonder about how much of this actually has been disseminated to hospitals right across England to understand about inclusiveness of, I suppose, ethnicity when audits have been done. About how much of that do we know? Two, colorectal cancer, which you obviously spoke about sickle cell, and I wonder about what other diseases are there that you're looking at the effect on minorities. We know that colorectal cancer is now beginning to affect younger and younger people, and we know that by second generation immigrants, the cancer starts going to the level of that. Again, obviously the problem issue with that is screening, and is also screening amongst ethnic minorities, whether you're doing any work about that. And then the third part is not a question as much, but rather an ask. You are alumni in the United Kingdom. We are at the moment publishing a new journal, and I wonder what I can get you to write an article on how we move forward with health inequalities in the United Kingdom for the journal. That would be a wonderful privilege if we can do that.
Thank you so much for those questions. If I may start with the question around audit, I think you will find that what we didn't have historically, I was saying during my speech about HQIP, which is the organization that runs the audit program on behalf of NHS England. They have redesigned their audit infrastructure to be able to do so on the basis of that disaggregated data. I recognize that that's at a national level, but it is a powerful frame of reference for what happens in individual institutions. The second point around ethnicity data, one of the things we did when I was in NHS England, two things, and if it's possible to put it in the chat box, that would be wonderful, is we published the Ethnicity Recording Improvement Plan. And this was a guide for all NHS organizations to ensure that actually they pick up the pace in terms of the completeness of recording people's ethnicity in their individual specialties. So that's one of the things. The other thing we did is actually use the legislation. And so we published 2 years ago a document titled The Statement of Information on Health Inequalities. And this forms a legal basis for NHS organizations to record data on inequalities, including ethnicity. What I will say is quite often we make these policy advancements nationally. It is then beholden upon local colleagues to hold their organizations to account. We do try to hold to account from the center, but it's more effective when it's being done by people operating within the system to say, NHS England has published this recording improvement plan. Where are we in our hospital? There is this statement on health inequalities data. Where are we in this organization? So in terms of the policy levers, they're there. Your point about cancer, when I talked about Core 20+5, one of the 5 clinical focus areas of Core 20+5 is early cancer diagnosis. And so we did a lot of work in terms of screening uptake. because we know whether it's breast cancer screening uptake, colorectal cancer, whatever the screening program is, whatever data set you look at, the uptake amongst Black African, Black Caribbean people is almost consistently lower than other population groups. And that is why early cancer diagnosis is one of the focus areas of Core 20+5. The idea being that we use the Core 20 Plus connectors. These are lay people, trusted voices, trusted faces, people who can have a very frank conversation that is not just a professional conversation, because with respect, people are more likely to listen to trusted voices in their own community than what the NHS says. And that's why we mobilize the Core 20 Plus connectors and ambassadors. So my suggestion would be, whatever your institution happens to be, do please find out who those local voices are. They are the ones who make the difference in terms of encouraging people to come forward and take up these cancer screening programs. Thank you very much for the kind invitation to collaborate on your journal. If you would be so kind as to email the organizers of this webinar, and I'm sure they'll forward that on to me, and we can have a conversation. Thank you.
Lovely. Thank you, Professor Owolabi. There are questions in the chat. So Dr. Shadia Mokodian will come to you. Professor Olale will come to you. But I need to yield the floor to Emeritus Professor Oluwole Akonde, following which I'll hand over to Dr. Usoro to take the questions in the chat. Professor Oluwole Akonde, sir, over to you, sir.
Well, thank you very much. I really want to congratulate Professor Bola Owolabi on an excellent and well-read presentation. And not only that, I wish to congratulate her on successfully putting together this partnership that she has described. It's really very impressive. I look forward to the write-up that is going to be in the journal, which Dr. Adedeji had invited her to contribute to. I will also want the organizers of the webinar to send us the slides that she has projected. Really very impressive. Once again, hearty congratulations on your excellent presentation and the success you have made in the United Kingdom. You really make us very proud. Thank you very much. God bless you.
Thank you, sir.
Thank you so much, sir. That means the world to me. I hold you, sir, and all my distinguished lecturers and teachers in the highest regard. And coming from you, that means more than you'll ever know. Thank you so much, sir.
Thank you.
Thank you.
Dr. Usoro, please take the questions in the chat.
Okay, I think I'm going with the first question. The first question is from Dr. Jaye Olale, and it reads, we often talk about disaggregating data to understand inequalities, but in practice, the data can be incomplete, inconsistently recorded, or too crude to reflect lived experience. From your perspective, how do we avoid drawing false reassurance or false conclusions from imperfect data? How can this be effectively challenged? Thank you. From Dr. Jaye Olale.
Dr. Jaye Olale, it's wonderful to have you on the call. Thank you. It's a really important question. I often talk about disaggregating data, but of course, the disaggregated data only makes sense if it's accurate in the first place. But I will say a number of things. Sometimes the completeness or the accuracy of data is often used as a diversionary tactic. And it's really important that we are wary of that. If I give you an example, prostate cancer in Black men. We know that Black men have double the incidence of prostate cancer. For the general population, it's 1 in 4. For Black men, it's for the general population, it's 1 in 8. For Black men, it's 1 in 4. They typically are diagnosed at a later stage and they have a worse outcome. The data has been there for years. And yet every attempt to stand up a national targeted prostate cancer screening program has failed. And what has always been held up is the data. So much so that in conversation with the NIHR and Prostate Cancer UK, a 47 million transform trial was stood up to try and make the case that has already been comprehensively made by existing data. This trial, we're talking about another 10 years to make the case that is already made. In that time, Black men will continue, sadly, to die, avoidably, of prostate cancer. And so whilst I'm a big believer in the data being complete, I also have a visceral reaction when data completeness or accuracy starts to be used, and I've seen this happen, as a diversionary tactic to not do the right thing by minority population groups. By all means, let's work incredibly hard. That's why we published the Ethnicity Recording Improvement Plan. That's why we published the statement of inequalities data. That's why we've done all of those things. But the thing we need to be alert and agile to is the danger that narrative is used to divert from data that is already there and comprehensively making a case. And that's why I talk about the pivot from analysis to action.
Lovely, thank you. We'll take the second question in the chat.
Thank you very much. The second question in the chat is from Professor Emmanuel Otoluri, and he asks, do you think that AI, artificial intelligence, will significantly impact medical practice globally? And which jobs are most at risk? Thank you.
Professor Otoluri, it's a distinct honor to have you on the call and to have you ask me a question. Thank you for joining us, sir. AI has already transformed the healthcare landscape, and it's only going to accelerate. I do see it as an enabler for the most part. However, specialties that are more around pattern recognition, particularly around data-led pattern recognition, are the most vulnerable, would be my view, because at the end of the day, AI is about large language models and learning. And so the specialties, one of my, I'm not going to mention any particular specialty, but one of my nephews was thinking about going into a medical specialty, and I said to him, in just 5 years, I think you will find that that specialty is obsolete, because a lot of it is about pattern recognition and data-led pattern recognition. So those are the specialties I think that will be particularly vulnerable as we go forward. However, the thing that I don't see becoming vulnerable anytime soon is the human contact, the human interaction with our patients. And I think the more we invest in developing, that bedside manner, people will forget what we did, but they'll remember how we made them feel. All of those sorts of things that Maya Angelou said. I think we need to focus more on experiential medicine, not simply technical medicine. And so our medical schools up and down the country, all over the world, need to pay closer attention and give parity of esteem to experiential learning as much as we do to the technical. Because I think historically, our orientation has been more towards the technical, quite rightly so. But I think medicine will survive into the future if we anchor to that human, that most human of all abilities, which is the experience of another person in our proximity. That would be my general observation, but you're right, AI is here and it's only going to accelerate.
Yeah, thank you for that comment, Professor Owolabi. I did ask AI about emotions, and AI told me that it hasn't got emotions. And one of the things that have made me who I am today is what I learned from the University of Ibadan, where my teachers then would say, if this were your family member, how would you want them to be treated? So that human interaction is very, very important. So thank you for buttressing that again. Dr. Osoro, do we have any further questions, or should we go to Dr. Omakodian, Folashade Omakodian?
No more questions in the chat. Thank you.
Lovely, thank you. So Dr. Omakodian, over to you, please.
Good evening, everyone, and my seniors, professors, Professor Emeritus Professor, all on the platform. I want to congratulate Professor Owolabi for the work she's done in the UK. Very courageous of you to go into a place where you're a minority yourself, and you're able to challenge the system and work your way through to reduce the inequities in health. And you've talked about collaboration, and I wonder if you actually can collaborate with ICOMAA, because I work in the Department of Community Medicine, and all that you talked about was resonating with me, and I was, looking at it in the terms of how can we fix something small in Nigeria? Nigeria is so big. How can we fix something small in Nigeria? Can we share from your experience in the Department of Community Medicine, in the Department of Health Policy? Can we share from your experience? In fact, the other thing you were sharing about the policy and the mechanisms you have made available for sickle cell patients. We've got loads of them here. Is there any way we can collaborate with you so that we can be enriched by your work in the UK? Thank you very much.
Professor Omakodian, what an honor. I still remember walking along the corridor of your office. I've even got goosebumps just remembering it. Wow. Thank you for being such a powerful, enabling teacher. That's how I remember you. Thank you. And it would be my honor and privilege to collaborate with ICOMAA. Only yesterday, I was talking to an organization called MA Global that have been supporting as they've been tackling maternal mortality in Bangladesh, Afghanistan, and Pakistan, about the model they've adopted and the transferability of that to Nigeria, literally just yesterday. And also, as you've mentioned, in terms of sickle cell, I would be so honored and delighted to be able to collaborate with you and the faculty on the areas that you've just been talking about there. So I very much look forward to the conversation going forward from here. Thank you so much for joining the call and for lecturing me.
Thank you. Professor Oladejo Olaleye, I think, joining us from the Middle East. Professor Olaleye. Yeah. Over to you. Thank you.
Good evening, everyone. I'm Oladejo Olaleye. I'm the Executive Secretary of the class of 2000, the proud class of 2002. We're a force for good, and I firstly want to say thank you to Dr. Osoro, who's part of the webinar organizing committee. She's our class. Tony Anani, who's a Gen Sec for ICOMAA North America as well. He's our class. So you will see that we are a force for positive change in the College of Medicine. Professor Bola Owolabi, CBE, you are our inspiration to me, to every generation, coming after you. Thank you for all that you have done. I speak as someone who has had firsthand interactions and experience with the people on ground in the grassroots who have run with the Core 20 Plus initiative, who have sat down with communities, who have engaged with early cancer prevention teams, and they are proud of the initiative that you have set up. And you've engaged a lot of people, ambassadors, connectors. I've met all of them in Leicester. They are really proud of the work that you have done. I'm proud of you, and so is everybody else on this call. You have been a champion of equality, and I don't say that lightly. Your leadership in the NHS in England has been inspiring, because you've gone in at a time when there was COVID, and you rightly pointed out that the disparities that we already know were widened by COVID. I saw that in my clinical practice in Leicester. Patients of ethnic minority backgrounds were coming in a late stage disease with cancer because we said they should stay at home, and they had lots of other reasons why they didn't want to turn out. There are lots of cultural reasons, nuances, fears, distrust of the system. The very people the COVID vaccine was meant to protect were the ones who did not want to take the vaccine in Leicester. They were worried. They said to me that, are we guinea pigs? Why is the government asking the blacks to come forward? So I've heard lots of things in the grassroots. So you came in at a point where it was really important to address health inequalities. It was widening, and it continues to widen, unfortunately. So we do need to do a work of mitigating the effects that COVID has wrought. I will say the Core 20 Plus 5 initiative was impactful. Not just in terms of COVID, but beyond that, with the cancer prevention, cancer diagnosis strand, which is where I come in. I worked a lot with the minority communities in Leicester, Black communities, Asian communities, met for several months, sat down, listened to them, brought them into a safe space. And I think that approach is a really positive thing. And I want to thank you for coming to the Leicester Equality Summit. We were all proud to meet you there. But I think co-designing in interventions with communities is the way to go. Sitting with them, listening to them, creating safe spaces for them. I think it's important, as you've said, to involve the critical voices, the pastors, the imams. You will not imagine the damage that some of the major pastors did during the COVID pandemic as regards vaccines and vaccines hesitancy. So I think it would be great to create those safe spaces and to redesign NHS services. We need to think a lot more about how do we bring the services into the communities. A lot of the Black communities said, we don't feel completely safe coming into hospital. Can you bring the service into communities? So I think that will be something to think about. I will say that funding for community engagement at that level was really difficult to come by, and you know that. And it's great to see the work you've done with the NIHR, getting key funding across some of the inequality strands. I think it'll be good to look a lot more around community engagement funding at the grassroots, because that's where the people are and that's where you get the answers. People feel empowered when you involve them in co-designing interventions. It is more likely to be impactful when they feel that they've got ownership of it. So in closing, I would say, yes, funding for community engagement, if it is possible to think about how we can actually get the funds to the connectors, the ambassadors on ground, away from the red tape. And then what lessons you think you can suggest for Nigeria in terms of reducing health inequality? That's a big question, but you've learned a lot as you're a top orga. You've learned a lot as NHS, Director for Equalities. What can Nigeria learn from your experience? Thank you so much for your attention.
Right.
Professor,
before you take the that last answer, I think perhaps that will come towards the end, because I think we should be Nigeria focused, and we want to give you time to address that a lot. But I'll ask Professor Asinobi to come in, and then you can take the two questions from Dejo. And we're here till 7, so we've got about 10 minutes. And so, Professor, I think, have you put your hands down, Professor Asinobi?
No, please. Thank you very
please.
much. Yeah. And to also remind you that Professor Olumide is on the call. Maybe we'll give her the opportunity to speak, please. But I want to thank you, Professor Bola Owolabi. We are so proud. I can't thank you enough. But I wrote there, please come over to Macedonia and help us. Professor Mokodion, Mrs. had said something, invited you to the College of Medicine. But we need you also in Nigeria. If they don't invite you, please, we have somebody like you. I mean, they will not invite you. If they don't invite you, please find a way to make an impact in Nigeria. Our healthcare system is not working effectively. In whichever small way you can help us, come over to Macedonia and help us. Thank you. God bless you.
Lovely. Thank you for that. Professor Olumide is online, one of our teachers. Over to you, Ma. While she's trying to unmute her microphone, Akintunde Odukobe, please, over to you. That might be the last question before we hand over to Professor Owolabi. Akintunde Odukobe, please.
Good evening, Professor Jaisimi.
Good evening.
And good evening, everyone. And thank you, Professor Owolabi, for that wonderful presentation. Interestingly, what you've described about the Blacks in diaspora, but it's not only in the UK, being underserved and also, very importantly, not taking part in preventive measures. It's happening here. And also, because you have so many families being there, the influence is so great that they tell them about vaccines especially. And it's saddening for one to see a patient that you took antenatal care and delivery, and then only to hear that, oh, I didn't take vaccines for my child. Very sad. But on the flip side, it's something that is happening recently. You see someone who has come into your clinic and you advise this test, you advise that test, and you lay out your plans. She says she doesn't have much money, only for her to come about 2-3 months time to say that they've been to doctors in the UK and they get thrown back that, we can't do much for you here, go back to Nigeria. So clearly, two things. Prevention is being hampered and money is being wasted on traveling to the UK. So they believe in the healthcare system in the UK. It's profound. It's still very, from time immemorial, people have believed that. But then not the total package, just the curative aspect. They believe that UK doctors will do fantastic and they will make money available for that. But usually, cancers will have to come here. 80% of them are in stages 3 and 4. When even over there, they can't do much. But the vaccine that will prevent future generations, the people are not taking. So very worrisome. So what if you have been able to identify the core things that are making those blacks over there not accessing preventive measures. And if we can look at how much they are influencing those back home, because they believe when they tell them, oh, vaccine will cause this, chemotherapy will cause that, and things like that. So if you can. The second set are the medical students. I've been teaching medical students here now for 32 years. And there is this belief about, yes, I want to go and practice in England. But you will see that many of them are not equipped to do some of the things that you did. That being patient, being humble, and persevering. And you then wonder that you're not going to develop those attributes if you have not started looking at them now. Because by the time you get there, you can be swept off your feet. And sadly, I was very sad to learn that we have people who have trained as medical doctors here, but who are working as cleaners in hospitals over there. So that we try to let them know that if you are good, you'll be good everywhere. So, and if you are traveling, it will be very important for you over there. If you are not traveling, you'll be able to do your best and make the system to benefit from what has been given to you. Thank you very much for bringing out this very important topic, and I'll continue to wish you the very best. Thank you.
Lovely. Thank you. Dr. Eno Usoro, you've got your hands raised. Professor Owolabi, I hope you don't mind giving us a few extra minutes of your time. Okay, yes. Thank you.
I think this is just a comment. I don't know if you want to respond, Prof. So Dr. Tony Anani from the US said, emotional intelligence. So I think he was responding to Professor Tolomin's question. Emotional intelligence and native intelligence will be at a premium in the AI world. There is also a misconception that fields will be obsolete, but that has not occurred. Rather, it has created more work for radiology, for example, which was thought to be most affected. So I think it's more of a comment than anything else. Thank you.
Right. We're on the home straight. Before we have your final response, and before we have the closing remarks and vote of thanks, just to ask you, because I said we should be Nigerian oriented or focused at the moment. We're all Black, so there's no difference. I'm playing devil's advocate here. We're all Black, so the drugs that works in me should work in you. But we know that genomics come into play in spite of skin color. You may want to address that when it comes to health inequality. And then the Jesse, gender equity and social inclusion as well. Perhaps you may want to say a word or two about that. So I will hand over the podium to you, Professor Owolabi. Thank you.
Thank you, Professor Jaisimi, and do forgive me if the answers are not fulsome and detailed. I'm very, very respectful of all our time. So, Professor Sinobi, thank you for your very kind comments. And as I said in response to Professor Omokodion, it is something that has weighed very heavily on my mind. There are no silver bullets, but at the very least, we can try. And I did try. I particularly after we launched the Casgevi here in the UK, I reached out to a particular healthcare department in Nigeria and said, I'm not asking you to invest 1.6 million pounds per patient, but I am asking you, is there something we can do? I'm glad to say it's not Ibadan, by the way. I'm glad to say it's not Oyo State. It's another one of the states in Nigeria, about preventative interventions for people living with sickle cell. Hydroxyurea costs pence. there are simple interventions, vaccination, and so on. And we had meetings for 1.5 years, 7 till 9 p.m. on Fridays in my time. We got absolutely nowhere until somebody very kindly rang me and said, Prof, they're wasting your time. You're far better off maybe just working with the communities directly. I felt I needed to say that because it was very disheartening, particularly when you consider that we have been able to make some progress here. And so maybe what I should have done is I should have come home. I should have come to Ibadan. Because I'm sure that will not have happened in Ibadan. So that's me saying thank you so much for that very kind invitation. And I really would love the opportunity to take the conversation forward. As much to learn from you as well. I don't have the answers. I always say the answer lies between us. And so I'm really looking forward to the conversations. Professor Olaleye, thank you so much. It was wonderful to come and spend time with you in Leicester. And there is nothing more encouraging than when you sit at a national level, leveraging policy, legislation, all those big infrastructure of state. When you then go to the front line and you find your colleagues making the most of those levers, I cannot tell you how heartening it is. And spending time with Professor Olaleye, as he rightly said, consultant ENT surgeon, robotic surgery, by the way, the work he did to translate Core 20+5 in Leicester at the front line, my hat's off to you. Thank you for doing it. And your question about communities and how we galvanize communities, you're right. Oftentimes, it's two things. One, professionals think we know all the answers, and we don't recognize that in the end, it's the communities that know the most cost-effective, creative, innovative solutions for their issues, if only we ask them. And therefore, I think there is a humility of asking our communities about what will work for them. The funding point is a really important one. Many of you will be aware that NHS England itself is being abolished and will be absorbed into the Department of Health and Social Care with all that that means. And as a matter of fact, recognizing that, I accepted a commission from the National Community Lottery Fund, which is a hundreds of millions pounds organization. And they asked me to come and be their innovator in residence. And the advice that I've been giving them is how that enormous institution puts its weight behind community level action. They're very keen to do it. I am honored to have been asked, to be their innovator in residence. And my hope is that as a result of this collaboration with them, you see, we're back to partnership. It's always through partnership. My hope is that through this partnership with such a well-endowed organization, that we can make some inroads in terms of investment in community level infrastructure, as you were saying, Professor Olaleye. Dr. Odukogbe, your point about preventative interventions, I'm really pleased to say that I'm honored to be part of the Women in Healthcare Network, which is run by Professor Mrs. Modupe Elebute Odusi, who is our founder and chair. And she, in collaboration with others, have started this huge program in Ogun State, which is about HPV vaccination uptake. As you know, cervical cancer is now fast becoming one of the vaccine preventable cancers. And I'm pleased that Wichen have launched this intervention. I hope that we can build on the momentum of that and do more. Again, that's a grassroots Nigerian-based. I had the privilege of going to visit her at her specialist cancer center, Marcel Ruth, in Lagos, and to see the work that they're doing there. So I think it's about education, trusted voices. The day that Jesus House London opened their doors to the COVID vaccine, I cannot tell you how transformational that was. And it was Pastor Tony Agu, who very kindly, and he asked all the right questions, but ultimately, and I remember saying to the Prime Minister at the time, Boris Johnson, and his office, please don't go to Jesus' house yet. Because everybody wanted to be straight in there, and we managed to hold them back for 2 weeks because they were so stunned by the level of response. It's all about the trusted voices. And I would say that we all do well to honor our faith leaders. They are the custodians of the trust of our population. We won't get very far without them. And whatever energy we need to invest in taking them with us, we do well to invest that energy. That is what I learned from the pandemic and subsequently. The point about genomics, Professor Jaisimi, is a point very well made. And I was very privileged to sit on the advisory board of Genomics England, precisely because of the point that you've made there around as genomics and precision medicine take off. We need to be especially alert and making the case, which is why I was so keen to point out this new chemotherapy extended gene variant testing that was launched in the UK only last week. It's really important that we're not naive. Precision medicine and genomics is not necessarily going to narrow the health inequalities gap. As a matter of fact, it has the distinct potential of widening the gap unless good people like yourself, Professor Jaisimi, and others on this call are making the case that actually it is about equity, not equality. And we continue to make the case and demand for that equity to be the case. In terms of gender equity, it's a very, very big topic, as you know. It's going to take more than the 1 minute that we have on this call to unpack, that space, but a lot for us to do there, no doubt.
I'm sure we'll have you back at another point in time. Before I hand over, I just want to say a huge thank you to you, Professor Bola Owolabi. I'm not doing the vote of thanks, but I think before I hand over the mic, is just to express my own personal appreciation to you and to all my teachers present in the audience. I greet you, Professor Akonde, Professor Olumide, my seniors, the Amakodians. I say hello to you. So I will be handing over.
Thank you,
I
sir.
understand Professor Manuel Olumide, she's got an unstable connection, but we've gone around technology, so she will be able to give her vote of thanks.
Thank you, sir.
Professor Manuel Olumide.
Good evening, everybody.
She's using a WhatsApp on a microphone, so we'll see whether it works.
Unusual meeting because I'm speaking to you through not just through my own microphone, but also through Omokojo's microphone because of my unstable connection. He called me and I'm speaking to him through his phone to you. So I hope you can hear. Can you hear me at all?
Yeah, we can hear you.
Oh, great. Well, I'm just going to say very few words. I'm an old friend, so you will please pardon me. First of all, I must say a very big thank you. I cannot thank you enough, Professor Owolabi, for this beautiful, magnificent, brilliant lecture that you have given us. Well, it's not even a lecture, well, it's more like an inaugural, address. Beautiful, well done. Obviously, you are somebody who is on top of their skills. I can see that you are a public health person, but it's not just in theory. You have put it into practice. All that we public health physicians to be and to do is what you have been doing. And we are so very proud of you. Extremely proud of you. As I was listening to you, my head was just getting bigger and bigger. It's just it's a good thing that you can't even see the head now, because it is a hydrocephalic head, it's not very thing. So Professor Owolabi is a teacher. Thank you very much, my dear. You have done so well. We are so proud of you. And I was just thinking as we were talking that, this all these things that this young lady has done, these are all the things that we had hoped when we were training as public health physicians in Britain. We were training and hoping that yes, we'll be able to be in positions where we can do these things. So my dear, I'm giving my life to you. Thank you very, very much indeed for doing us all proud. We are all very proud of you. And to the rest of us all listening, I want to say that we hear good news of you all the time. You have all done us so proud. You have all made it so well. These are all the services we get, all the sacrifices we get. You have made it worthwhile. I pray for all of you that you will only go from strength to strength, from glory to glory. Thank you very much for the honor you have done me.
Yeah, thank you, Professor Manuel Lumide, for that. Before I call Dr. Adeyemi Adedeji, I think my final and passing word is that vision that we have individually and collectively, the vision should not remain on the dashboard. Let us turn it into action. And once again, thank you for the honor you've accorded me to be the chairman at this evening's webinar. Over to you, Dr. Adeyemi Adedeji. Thank you.
Thank you very much, Prof. First of all, I would just want to say thank you very much on behalf of ICOMAA UK and Ireland. We are indeed very grateful to Professor Owolabi for the well-delivered webinar. Like we've all heard, progress actually is a continuum. I looked at a word that has been written on marble here. It says progress, no matter how slow or imperfect, is the ultimate goal, requiring consistent action and a growth mindset rather than perfection. So I joined the clarion call to ask Professor Owolabi to all the work that you have done in the UK to collaborate with the College of Medicine, University of Ibadan, and bring everything to light. And we'll be rooting for you, the CBE that you run in the UK, to actually to get an MON in Nigeria. We'll all be looking forward to that time when it will come to fruition. So without wasting much time, I don't want to go through the list, but if I would just have to go through few lists here. Most importantly, I have to recognize our teachers, the elders in the house, Emeritus Professor Oluwole Akande, Emeritus Professor Emmanuel Otolorin. They are always very present in everything that we do in the UK and the Ireland branch. Our Professor Samuel Omokodion, the president of ICOMAA Worldwide. We are indeed very grateful for that brief remark that you made at the start of the webinar. Then we have Professor Omiwodun. I saw her briefly there. I don't know whether she's still on the call. Thank you very much. You have been an inspiration to us all. Professor, Dr. B.C. Oshikalu, and then Dr. Modupe Shokubi, thank you very much for attending this program. And then I want to recognize the chairman of the day, Professor Ruchi Bijayesimi, and then the mother of the day, Professor Aderonke Manualubide. Thank you very much, Ma, for that inspiring word, those inspiring words that you just gave now. Chairperson of the webinar committee, Professor Asinobi, thank you very much. We very much appreciate you. Then the webinar committee for the UK and Ireland, ably represented by Dr. Eno Osoro. Thank you very much. And all the members of the UK and Ireland that joined despite all your tight schedule and busy schedule. And then worldwide, everybody that joined, I saw a few people there. I could recognize their faces and names from North America, from Australia, from Nigeria, from Ireland, from the UK. Thank you very much. God bless you all.
Thank you.
Thank you.
So do have a good evening, and let's network, let's keep in touch and keep the conversation going. Thank you.
Thank you, everybody.
Thank you
Good
so
night.
much.
Thank you.
Enjoy the rest of the evening and the weekend.
Thank you. I want to
Thank you,
also
Professor
thank.
Jaisimi. Thank you so much.
Thank you, everyone.
Thank you, Professor
Thank you,
Jaisimi.
Professor.
Thank you,
Thank you,
Dele
Professor Owolabi.
Shokumbi.
Thank you so
Dele
much.
Shokumbi, Dr. Modupe Shokumbi's husband. He was there with us. Thank you.
Dr.
Thank
Dolamu
you,
Shokumbi.
Prof. Yes, Dolamu Shokumbi. Thank you. Prof. Owolabi, thank you once again. Thank you, Dr. Jile. Thank you, everyone. Thank you, Dr. Bukola Olaleye. Thank you. Thank you, everyone. Thank you, Mr. Yetunde. I appreciate everyone.
And we thank our IT team as well.
Yes, that's Yetunde. Yes.
They've given us the platform to be able to project this. Thank you so much. Have a wonderful evening and God bless you all. Bye-bye.
Amen. Bye, everyone.
It seemed as if it should not end.
Yes.
Thank you.